Dr. Sanjeev Gulati is an alumnus of Maulana. He is MD Pediatrics, DM Nephrology. He was additional professor of nephrology in SGPGI, and he's done his DM from AIMS. Dr. Sanjeev Gulati is at present Senior Consultant Director Nephrology at Fortis Escorts. Actually both places, Fortis Escorts, and he comes to Vasant Kunj also. He is also at present a very deserving, I would say, President of the Indian Society of Nephrology. Multiple awards and papers, national, international, to his credit. More important than that, he is a thorough gentleman who waits on our calls for his turn and lets the three speakers speak despite the fact that he is the first one to come. We owe it to you, Dr. Sanjeev. Thank you very much. He will be speaking on preventive nephrology, and I just asked him a very, I would say, stupid question. I said, is there something preventable in nephrology? He said, your field, hypertension, diabetes, you control them, patient never gets to us. Start your talk, sir. Thank you.
Thank you, Sushil. At the onset, I'd like to congratulate Dr. Almas on organizing this excellent meeting on World Holistic Day. I think it is a much needed aspect, especially for our country, because a lot of these diseases are a significant burden on the healthcare, and the primary role of the government should be in preventing healthcare, which is what we are talking today. So I think a lot of messages for the policy makers also. So as a nephrologist, I will be talking about prevention of chronic kidney disease. So this is what Sushil just asked. I think he, with his experience, peered into my first slide. Can we prevent CKD? And let's throw the dice and see. Yes, no, maybe. So at the end of the talk, I'm sure we'll come to a conclusion whether this is possible at all or not. Because CKD, as you all know, is a dreadful disease. It affects, not only the patient but also the family. It's a significant drain on the entire earnings of the family, and the outcomes always are not very gratifying. So first of all, just to quickly recapitulate what we understand by chronic kidney disease, how common it is, what causes CKD, what are the costs and consequences to the society of this growing epidemic of CKD, and what can be done to detect, prevent CKD and cardiovascular disease. So kidney disease as defined by KDIGO, which is the Kidney Disease International Global Outcome, is if there is abnormalities of kidney structure or function present for more than 3 months. So one measurement is not enough. You need at least 2 measurements over a 3-month period, and it's got implications for health. It is classified on the basis of the glomerular filtration rate as well as on the degree of proteinuria. So this is the most severe category, this is the mildest category, and obviously as the primary care physician, the challenge for all of you is to prevent patient from getting it here, that is we call the primary prevention, and then as a secondary prevention once they are here, to prevent them from graduating on to or delay the graduation from this to the last category, because here the cost implications are tremendous. So how common is it? Well, studies from our country have shown that previous studies, 15 to 20% of the general population has some degree of CKD. So if you are looking at 100 individuals in a community, 15 to 20 would have chronic kidney disease. But there is an ongoing study of the Indian Society of Nephrology which I initiated, and we have the preliminary data. It's a nationwide study. 1 lakh patients have been screened not only in Tier 1 but Tier 2 and Tier 3 cities throughout the country. 1100 primary care physicians have been part of this. They have partnered with us, and the preliminary results are alarming. The prevalence is now 30%. So it's increased by 50%. Globally, this is a very conservative estimate. 500 million individuals have some degree of CKD. Previous studies 100 million or more. So I would say that this is probably close to 200 million. Now, the etiology of chronic kidney disease, these are studies from 3 different institutes, including ours from SGPGI, PGI Chandigarh, Apollo Chennai, And we were among the first to point out that diabetic kidney disease was emerging as one of the important causes of chronic kidney disease. And when we looked in our study at the data more than 40 years, it was actually already the commonest cause of chronic kidney disease. Subsequent studies from PGI Chandigarh as well as Apollo Chennai from Dr. Mani's group have validated this. It was published in Kidney International. Now the economic burden is tremendous, especially for our country, which spends a very minuscule aspect of the GDP on healthcare. The costs are escalating. Worldwide, 1.5 million people are currently alive on dialysis or transplantation, and in our country every year we add roughly about 2 lakh people. And the number is forecasted to double within the next decade. I already told you we have already gone a 50% increase. The cumulative cost for dialysis and transplantation is expected to be $1 trillion over the next decade. So again, highlighting that it's high time that we talk about prevention. More than 80% of individuals receiving RRT live in the developed world, as it is unaffordable in the developing world. So dialysis and transplantation by and large, only the developed world can afford because it's subsidized. In India, less than 20% of our population receive renal replacement therapy, which means dialysis or kidney transplantation. And you can imagine what the 80%, they are left to die. That's the bitter truth. So the economic burden for developing countries is particularly severe, especially a country like ours, because CKD occurs at younger age here in our country. Now, majority of the individuals with early stage of CKD go undiagnosed, especially in countries like ours. Early detection is essential because it allows suitable treatment or prevention with more cost-effective methods. Obviously, dialysis and transplantation is very expensive, but the early treatment is very easily affordable. And it helps in preventing complications, the comorbidities, which add to the cost. And also, so if you are able to prevent that, you can cut down the treatment cost. And that's what I think we need to emphasize, especially to the general public. So let's look at the potential risk factors for susceptibility. And the 2 that stand out are diabetes and hypertension, and number 3, urinary stones. Why I have highlighted this? The 3 of these actually are all preventable to a large extent. You have autoimmune diseases, systemic infections, UTIs, obstruction, family history, previous acute kidney injury, low birth weight, obesity, smoking, again a very important preventable aspect. And as you can, by the end of this session, conference, you'll see some common messages coming out. I think already I see a lot of overlap between my talk and what Prashant said. Exposure to certain chemical environmental conditions. Pollution has come up now in a big way, especially in the etiology of chronic kidney disease. We have already talked about obesity, we have talked about smoking. So if you practice a holistic lifestyle, there is a lot of opportunity in preventing kidney disease. So I take you back to your physiology days. So this is the normal glomerular structure function. This is the afferent arteriole. It brings blood to the glomerulus. And this is the efferent arteriole, which takes the blood away from the glomerulus. And this is a normal, in a healthy individual. And let's see what happens to chronic kidney disease. So there is a decreased afferent arteriolar resistance. This is what happens, the hemodynamic changes, and there is increased resistance. So as a result of this, dilatation here, constriction here, there is increased glomerular capillary pressure, which causes proteinuria, which causes release of cytokines, and which causes fibrosis and chronic kidney disease progression. So if we remember this, now we have a lot of agents, we can actually reverse all this pathophysiology. And over the next few minutes, I'll walk you through that. So how do you prevent CKD? Well, first and foremost, identify people at risk. Who are those? Diabetics, hypertension, obesity, smokers, individuals over 50 years, and even patients who have a family history of diabetes, hypertension or kidney disease. So I think this is the target group. If we are talking about prevention in our day-to-day practice, we have to focus on this group and focus our efforts there. And in these patients, we should do simple tests, routine urine analysis, spot urine albumin creatinine ratio, serum creatinine and eGFR. I think all these tests don't cost a lot, maybe less than 1,000 rupees. And this is how we are doing screening as a part of the Indian Society of Nephrology community study. Now this is the importance of microalbuminuria in the development of diabetic nephropathy. They showed that those patients of diabetes who had urine albumin creatinine ratio less than 15 did not develop overt nephropathy, whereas if it was urine albumin ratio to protein ratio was more than 50-80% of them progressed to develop diabetic kidney disease. So this is at early on in the stage of diabetes, that's where you need to counsel your patients to be spend their money. So these are the strategies that once they have developed early evidence, what do you do? Well, meticulous blood pressure control, meticulous sugar control, discontinuation of smoking, restriction of non-vegetarian proteins, again highlighted by previous speakers, that vegetarian protein diet, something which has been ingrained in our scriptures also, is perhaps the most kidney friendly too. Treatment of hyperlipidemia, avoidance of nephrotoxins, and when I talk about nephrotoxins, I talk of any self-prescribed drugs, any untested, unvalidated, unscientific therapies which are being prescribed. The alternative systems of medicine need to do their homework and research so that they can select those groups and the doses which are good, those drugs. Radio contrast agents, again, need to be careful if you are subjecting these patients who have got even mild kidney disease. So impeccable blood pressure control, less than 130/80 and 120/70 if you have proteinuria, ACE or ARBs, I will come to this later. Meticulous blood sugar control, control anemia, lipids, stop smoking, and again physical activity and body weight control, which is coming out again and again. So certain common strategies which will give you multiple benefits. So what about RAS system has been actually over the last 2 decades the pillar of prevention of chronic kidney disease. They reduce albuminuria and prevent progressive renal failure, and they are effective in preventing progressive renal decline. So these are several studies over these last 2 or 3 decades. Trendy study, the detailed trial, the innovation, IRMA, Marvel 2, Microhope, Benedict, IDNT, Amedio, Vivaldi, which showed that you use these agents early on at the onset of hypertension, there is inhibition of progression of both diabetic and non-diabetic kidney disease. So in fact they are so good, I think we should put them in all our mineral water bottles and have them daily. Now this is again the landmark study, the Captopril trial published in New England Journal of Medicine. And here they found that this was doubling of the proteinuria. It was significantly lower in the placebo, in the captopril group as compared to placebo group. This is the importance of control of blood pressure, that the better the blood pressure control, the lower the proteinuria. RAS blockade, again it gives you added benefits. The risk of new onset diabetes in all these trials with that as compared to the comparator mark was significantly lower. So you are not only controlling blood pressure, you are not only reducing proteinuria, you are reducing the chances that this patient is developing diabetes later on. Again, this is what we need to counsel our patients, to impress upon them that the advantages are there. Now this is how diabetes and probably other diseases causes glomerular hypertension. So this is the proximal convoluted tubule where we have the sodium glucose transporter, and there is majority of the glucose as well as the sodium reabsorption takes place in the proximal convoluted tubule. So there is less sodium reaching in this in the macula densa. This is the afferent arteriole, and so once you have sodium reabsorption here, the macula densa sends a signal. There is to the afferent arteriole to cause afferent arteriole dilatation, and this is what the initiating factor is in diabetes. The day you develop hyperglycemia, this pathophysiology sets in, and as a result of this there is glomerular hypertrophy and there is hyperfiltration. So the day a patient develops diabetes, he develops glomerular hypertension and hyperfiltration, and now we have agents which can reverse this pathophysiology, and these are the SGLT2 inhibitors. What do? They block this. They act at the proximal convoluted tubule, they block the glucose reabsorption. So as a result, there is definitely more improved glycemic control, But along with that, there is renal protection, because now there is more sodium reaching the macula densa, and which in turn sends a signal to the afferent arteriole reversing. This is what I showed you was in chronic kidney disease. So these agents were investigated in diabetic kidney disease, and the subsequent trials, namely the DAPA CKD trial, showed that they work even in non-diabetic kidney disease, and there is reversal of glomerular hypertension. But the key is to use them early on. And there is reversal of the hyperfiltration that is happening. And these are the other pleiotropic benefits that you have with SGLT2 inhibition. So it is, you use it and you get 8 different advantages. And this is the landmark DAPA CKD trial, which showed, this was a placebo-controlled trial. I think most of us in this audience know this, that this showed that among patients with chronic kidney disease, the risk of any composite kidney or cardiovascular outcome or death was significantly lower with dapagliflozin than placebo, whether the patient had diabetic kidney disease or non-diabetic kidney disease. So that's why it went a step further, that it provided us a common therapy regardless of the underlying kidney disease, and that's why this paper was noted as the best paper. This was published in NEJM 2022, and it was the best paper in nephrology that year. This is a subgroup analysis of the Credicens trial, which actually preceded the DAPA CKD trial. But why I am showing you is that it looked at the question, what are the effects of canagliflozin in patients with type 2 diabetes and baseline EGFR less than 30. So advanced kidney disease, stage 4 and stage 5 kidney disease, 174 patients. And as you can see, this is the canagliflozin arm. It was a placebo-controlled trial, and this is the kidney failure AKI adverse benefits. And what it showed was that canagliflozin, even when you are using in stage 4 kidney disease, slowed progression without increasing the acute kidney injury in patients with diabetes and EGFR, any adverse risk factor. So at any stage, even in stage 4 CKD, the SGLT2 inhibitors retain their efficacy. So now we have agents which target, as I showed you here, the SGLT2 act at the afferent arteriole, the RAS blockade was acting at the efferent arteriole, and here by using a combination, there is synergy, that is here, normalization of interglomerular pressure, additive interglomerular pressure reduction, and potential for long-term renal protection. And this is a meta-analysis which has validated this. The combination of SGLT2 and RAS system blockers protective in type 2 diabetes and safe. Yes, the combination therapy with SGLT2 inhibitors and ASARs was effective, well tolerated, and could achieve additional clinical benefits. There was, however, an increased risk of hypoglycemia which we need to monitor. Now, inflammation and fibrosis is a potential treatment which has a residual risk. So we talked about the ACE and inhibitors ARBs which were affecting the hemodynamic pathway. I talked about the SGLT2 inhibitors which are affecting the metabolic pathway. But there is a third pathway in chronic kidney disease, which is the inflammatory fibrotic pathway. And till date, we did not have any existing treatments. But current and emerging therapies for CKD are primarily, as I showed you, were targeting only these two pathways. Do we have an agent? The answer is yes. Finally, we have an agent which is called finerenone. This is a novel, non-steroidal, selective mineralocorticoid receptor antagonist. So it is different from spironolactone. It is bulky. It's a non-steroidal molecule. The unique structure helps us in causing selective and potent interaction with the mineralocorticoid receptor and regulation of gene expression, and thereby causing very potent anti-fibrotic and anti-inflammatory effects. So the third pathway, this is the only drug till date which targets that. These are the two trials, the Fidelio DKD, Figario DKD, in different set of patients, and the Fidelity, which is a combined analysis, and it showed that the finerenone reduced the risk of cardiovascular mortality and morbidity by 14% and reduced the risk of progression by 23%. So there is a buy one get one free. You get renal protection, you get cardio protection if you are using this particular agent. Liraglutide is another agent which has been looked at, and in the leader trial it showed that the GLP-1 receptor analogs, again it has showed that this is an other agent which is renal protective. However, till date it has been used only in diabetic kidney disease, and we are waiting studies in non-diabetic kidney disease. So I come to the end of my talk. Is kidney disease preventable? And I think the answer is an unequivocal yes. How do you do that? It is possible to identify people at risk of CKD, screen with the CKD and using simple tests, institute effective preventive therapies which we just discussed, and thereby it makes it possible to detect and treat CKD. And these are the 7 golden rules to protect your kidneys. Again, common rules which will give you added benefits. Keep fit and active, maintain blood sugars, blood pressure, eat healthy and keep weight in check, do not smoke, avoid painkillers, antibiotics, and I must add, in our country, untested, unvalidated alternative therapies. Don't ignore mild symptoms, get annual tests if you have more than 40 years, simple tests like EGFR, urine and ultrasound, so that you detect kidney disease early. And I think this is the take-home message for this conference too, that it is the superior doctors who prevent this disease, and that is what I think Dr. Almas is trying to focus. Help us graduate from the 3rd category to the 1st category. It is the mediocre doctors who treat the disease before it is evident, and it is only the inferior doctors who treat the full-blown disease. Thank you for your attention.
Dr. Sanjeev, wonderful talk. Just few questions for everyone's benefit. We have Dr. Wadhwa here, who is heading the Department of Physical Medical Rehabilitation, and his work involves, apart from physiotherapy, rehabilitative therapy, a lot of painkillers to be given for pain relief. What painkillers are good for skeletal muscle pain, which do not interfere with the kidney functions, do not cause interstitial nephritis? Which is the safest painkiller?
So I think the safest painkiller till date is paracetamol. But at the same time, I agree that if you have inflammatory conditions, it is not often very effective. And in that cases, I think you have to screen your patients very carefully. Make sure that they are not in the elderly list. Make sure that you know their estimated GFR. They are not dehydrated. And if all these are, you can use, because pain relief is paramount, you can use non-steroidals, but before that, we also have gabapentin, we also have tramadol, so you can use these drugs before that. But yes, if you are pushed to use painkillers, use it in the lowest possible dose for the shortest duration and under careful monitoring.
There is a new molecule which has been launched in the last 5 years called Nifopam. What is your...
So all these, we had the non-selective, then we have COX-1 selective, then we had COX-2 selective. All of them are as good or as bad as far as kidney is concerned. There is no studies have shown that the COX-2 ones or any of the newer ones are more kidney safe than the previous ones. So at least for antibiotics, we should strongly educate paracetamol. I do agree that in day-to-day practice, once you are dealing with inflammatory conditions, we are pushed to using NSAIDs, but then do it, as I said earlier on, smallest dose, shortest possible duration and under monitoring.
You mentioned SGLT2 inhibitors, and you mentioned DAPA, CKD, and now DAPA being recognized and advocated by FDA to be used even in non-diabetic kidney disease. What is the status of Finrenol? Is it also...
So Finrenol, yes, that's a very good question. There is a Finrenol renal trial that is going on. I think the results are expected sometime next year. So as of now, we don't have evidence, but if you look at the pathophysiological basis, I am pretty sure the results of the DAPA CKD trial are going to be replicated. And as nephrologists, we are all excited about it, that we'll soon have another agent in our therapeutic armamentarium.
Just one point for everyone's benefit, when we start using Finrenol, it is very, very important to keep track of serum potassium.
Yeah.
That is like...
So don't start if the potassium is 5 or more. That's a very important point. I think for the constraints of time, we didn't have enough time to develop on the safety of this molecule. But yes, these are the agents, 3 or 4 agents which are there at our disposal. But maybe they cost a lot, but if you look at the cost of treating end-stage kidney disease and cardiovascular disease, the cost is minuscule. That's what I think we need to counsel our patients. Thank you.
Dr. Gulati, renal side effect of NSAIDs is dose dependent or dose independent?
Very good. So it is both. So one is, I'll talk about the dose dependent. So cumulative intake studies have shown of 5,000 tablets So it was difficult to quantify which, but because most of these patients take one day, take one drug, they said that the day you cross 5,000, then your risk of chronic interstitial nephritis increases. So that is one thing we need to. Then there is an idiosyncratic reaction that is almost impossible to predict as of today. That is called acute interstitial nephritis, which can occur even with a single dose. And here I think we need more research because we are not sure. In times to come, we'll have some genetic markers which will be able, to precisely identify. Because same drug we are using in hundreds of patients, and then at the 101st patient suddenly comes to us with acute kidney injury after just 1 or 2 doses. So it is impossible to predict as of now, but I'm sure in times to come we'll have genes which will be able to.
And amongst NSAIDs, do we have drugs which got more side effect than we don't have any?
No, they're all the same.
Sanjeev, no questions, only I would say token of gratitude to you for allowing Dr. Puneet before you, although you had a patient waiting, and that was so nice of you.
Just one question for the general public, because this is preventive this thing. When we talk of anti-inflammatory analgesics, in terms of days, what do you think, 15 days or 20 days, and then a gap of 1 month, another 15 days, because people take it chronically. So what that gap should be for people should understand?
I think, as I said, the shorter they take it, the better it is, and step down. What I would say is that use it initially, and the moment the pain is controlled, step down to something milder like paracetamol, because a lot of time I think these drugs are doing a placebo effect. They get dependent upon it, and the same holds true for PPIs, which our patients are literally get addicted to it, because studies are now available with PPIs also, that there is long-term kidney damage that is happening. So both these group of drugs, I think we should use with caution in our specialty.
Wonderfully summarized, Dr. Sanjeev.
Sir, one
Preventive CKD. Yeah, please, go ahead.
UTI is with SGLT2.
Sorry?
UTI, yeah. So the UTI risk with SGLT2 is actually overplayed. Most of these infections have been, genital infections, fungal UTIs, and I think good counseling of our patients, we are able to select out which patients you need to stop. But I think it's a minuscule, it's a very small percentage.
Thank you. I would request Dr. P.K. Gupta sir, President of the Forum, to do the honors to Dr. Sanjeev Gulati, and you carry a gratitude with you for being so patient.
No, not only that, I think it's a great privilege to be a part of this conference, and I think I salute the vision of the organizers, notably I think Dr. Sushil and he is truly a visionary, also I think an Indian multinational, if I can call him.